Imagine a microscopic invader that doesn't just, breach your body's fortress.
Right.
It actually breaks into the command center, rewrites your genetic blueprints, and it turns your own defense generals into enemy weapon factories.
And it does all of this while constantly mutating its disguise. I mean, by the time your immune system recognizes the specific threat, the invader has already changed its uniform.
Leaving your defenses basically fighting a ghost.
Exactly, yeah.
That is the terrifying yet honestly biologically ingenious mechanism of HIV. Welcome to the Deep Dive. If you are joining us to understand the underlying architecture of the things that shape our world, well, you are in the right place.
You really are.
Our mission today is to take you on a journey from the stealthy cellular mechanics of this virus all the way to the global public health policies that are deployed to stop it.
And we are synthesizing two very distinct sources for this analysis. First, we've got an accessible, public-facing overview from the CDC.
Right, for the big picture.
Yeah, and we're pairing that with a highly technical clinical reference from StatPearls. This was updated in 2026, and it provides the exact protocols and pharmacological data that doctors actually use to manage this condition on the front lines.
So we're going way beyond the surface level statistics here. You're going to understand not just the clinical timeline of an infection, but the absolute how and why of the virus's behavior.
And crucially, how modern medicine essentially traps it.
Okay, let's unpack this. Because to understand the medical counterattack, we really have to look at the virus's playbook first.
Right, and the sheer scale of what it has done. I mean, since it was identified in 1983, HIV has claimed approximately 44.1 million lives worldwide.
It's just a staggering number.
It is. And in 2024, there are 40.8 million people currently living with it.
But, the epidemiological data shows a really massive split in how the world is handling those numbers today.
Yeah.
Globally, new infections have actually dropped 40% since 2010. Eastern and Southern Africa, which was historically the epicenter, they drove a huge portion of that decline through these massive public health campaigns.
They did, but the StatPearls text highlights a pretty stark countertrend. In the Middle East and North Africa, new infections didn't drop at all. They actually surged by 94% over that same period.
Wait, 94%? That's almost double.
Yeah, it's a huge increase. And the sources attribute this specific regional spike to challenging legal environments, human rights issues, and military conflict. It just proves that a virus thrives anywhere a society's infrastructure is fractured.
Wow. Well, let's zoom into the biological infrastructure that it targets.
Yeah.
Because HIV is a retrovirus, but the clinical text specifically categorizes it as part of the lentivirus genus.
And that classification is so crucial. Lenti is Latin for slow. So this isn't a virus that, kills the host in a matter of days.
Right, it's a long game.
Exactly. It is characterized by a very long, slow incubation period.
And it exclusively hunts your CD4 positive T lymphocyte helper cells. Those are basically the coordinators of your immune system.
Right.
If your immune system is an army, the CD4 cells, they aren't the foot soldiers. They are the generals giving the attack orders.
We should probably also clarify that we are dealing with two distinct viruses here, HIV-1 and HIV-2.
Oh, right.
They actually crossed over from completely different animal populations in separate historical zoonotic events. Genetically, their amino acid structures are only about 60% identical.
Which is wild to think about.
Yeah, and HIV-1 is the highly transmissible one. That's what drives the global pandemic, whereas HIV-2 is mostly concentrated in West Africa, and it progresses much more slowly.
So the truly sinister part of HIV-1 is its replication process.
Yeah.
Because, human cells normally transcribe DNA into RNA.
Right, that's the standard flow of genetic information.
But HIV brings its own RNA, and it uses an enzyme called reverse transcriptase to just run the whole process backward. It turns its RNA into DNA.
It's so backwards.
It's like a rogue architect sneaking into a construction site. Instead of blowing up the building, they translate their foreign blueprints into the company's proprietary format, slip them into the master file, and suddenly the factory is churning out enemy weapons.
What's fascinating here is the sheer sloppiness of that rogue architect.
Sloppiness.
Yeah, because when human cells divide and copy DNA naturally, they have a built-in proofreading mechanism to fix typos. But reverse transcriptase has zero proofreading ability. I mean, none.
Oh, wow.
It makes 100 to 1,000 times more errors than normal cell division.
So it's essentially a mutation engine then. Every mistake just creates a slightly different version of the virus.
Which is exactly why it was historically so incredibly difficult to treat. It generates massive genomic diversification. So A single patient doesn't have, one version of HIV.
Right.
They have a constantly evolving swarm of viral variants that can just quickly outsmart a single medication.
But how does this actually kill the CD4 cells, though? Like, does the virus just fill them up until they pop?
Well, sometimes, yes. Massive viral replication can literally cause the cell to burst. But more often than not, it's a tragic case of friendly fire.
Friendly fire. How so?
So the infected CD4 cell starts displaying these viral proteins on its surface. Other immune cells, called cytotoxic T cells, they recognize that the general has been compromised and they destroy it.
Oh, man.
Alternatively, the virus triggers apoptosis, which is essentially programmed cell suicide. The immune system is basically tricked into destroying its own leadership.
That is brutal. And because it operates by stealth, infiltrating the DNA and mutating constantly, the timeline of an infection is incredibly strict.
Right. Very strict.
And detecting it requires catching it in very specific windows.
Yeah, the clinical guidelines map out those early days really clearly. Right after exposure, you enter what's called the eclipse period.
The eclipse period. So if you were to look at a drop of your own blood under a microscope on, say, day 8 of an infection,
You would see absolutely nothing.
nothing at all.
Nothing. You would feel perfectly healthy, and honestly, no current medical technology could tell you otherwise. The virus is just quietly establishing its foothold.
That's terrifying.
But then, between 2 to 4 weeks, that localized infection just explodes into the bloodstream. This is acute HIV. A patient experiences intense viremia, which is a massive viral load in the blood.
And the CDC points out that the body finally sounds the alarm here, which results in flu-like symptoms for a lot of people.
Right. Fever, severe fatigue, swollen lymph nodes.
And the Stat Pearls text details some very specific clinical signs that doctors look for, like mucocutaneous ulcers.
Yes.
These are very distinct, shallow ulcers with a white base and a red ring, and they can appear in the mouth or throat.
Exactly. And after that acute battle, the immune system rallies just enough to suppress that massive viral explosion. It establishes what clinicians call a viral set point.
Okay, set point.
Yeah, and this transition pushes the patient into the chronic phase of the disease, which honors that lente or slow virus classification we talked about.
Right, because this phase can last for years, and it's largely asymptomatic.
Yes.
But the war is just happening underground, slowly grinding down the CD4 count until it drops below 200 cells per cubic millimeter of blood.
And that threshold, under 200, that is the clinical definition of acquired immunodeficiency syndrome, or AIDS.
This is where the opportunistic illnesses strike. The sources list conditions that, a normal immune system would just swat away effortlessly.
Like pneumocystis jirovecii pneumonia, or PCP. That's a really severe fungal infection in the lungs.
Or Kaposi sarcoma, which is a cancer triggered by another virus entirely. Or severe invasive candidiasis. Basically, the foot soldiers just have no generals left to tell them what to do.
Which highlights exactly why early intervention is so critical.
But wait, I'm a bit confused about the testing aspect of this. If the acute phase just feels like the flu, how on earth is anyone supposed to know to get tested? I mean, if the virus integrates its DNA into the host cells and goes completely dormant during the chronic phase, meaning no symptoms, seemingly no activity, how can a blood test actually find it? Shouldn't the virus be invisible until it drops your CD4 count?
It's a great question, but dormancy in the chronic phase is a bit of an illusion. The virus isn't completely frozen. It's still replicating, just at a slow, steady rate.
Oh, I see.
And that's exactly what modern fourth-generation antigen antibody tests look for. They don't just look for your body's antibodies, which can take weeks or even months to develop. They actively hunt for the P24 antigen.
The P24 antigen.
Yes, it's a very specific structural protein that makes up the virus's outer core, its capsid. Because the virus is still slowly churning out copies, the P24 protein is floating in the blood.
Got it.
So by detecting the actual physical debris of the virus, doctors can diagnose the infection long before the immune system collapses.
And catching it before that collapse changes absolutely everything. I mean, this is where the medical narrative shifts from observation to overwhelming suppression.
Yes.
Antiretroviral therapy, or ART, is what turned a fatal diagnosis into a manageable chronic illness.
And the 2026 guidelines are emphatic about this. Treatment must begin the moment a diagnosis is confirmed. You do not wait for symptoms, and you absolutely do not wait for the CD4 count to drop.
Here's where it gets really interesting. The Stat Pearls text breaks down the drug classes, and it is honestly a masterclass in biological engineering. You have NRTIs, NNRTIs, protease inhibitors, and NSTIs.
It's a lot of acronyms.
It is, yeah.
Yeah.
But let's look at how these actually work because they attack the virus at completely different stages of its life cycle. It's like setting up a gauntlet of security checkpoints.
Yeah, exactly. And the current preferred first-line defense is a combination therapy. The guidelines recommend an NSTI-based therapy using drugs like bictegravir or dolutegravir combined with a dual NRTI backbone.
Right. So an NRTI works by feeding the virus fake genetic building blocks. When that rogue architect we mentioned tries to copy its blueprint, it grabs this fake building block and the whole DNA chain just snaps. It completely sabotages the cloning process. But what about the NNRTIs?
So NNRTIs approach the exact same problem but differently. Instead of offering a fake building block, they bind directly to the reverse transcriptase enzyme itself. They physically jam the gears so the machine just can't operate.
Wow. And if the virus manages to get past those, you have NSTIs integrase strand transfer inhibitors. These literally block the enzyme that the virus uses to splice its newly minted DNA into your genome.
Right.
It's basically like putting a padlock on the master file.
And we should definitely also mention protease inhibitors, or PIs. Even if a virus successfully hijacks a cell and creates new viral material, that material is raw and unusable at first.
Right, it needs to be processed.
Yeah, it requires an enzyme called protease to act like molecular scissors, cutting the proteins into functional pieces. PIs basically gum up those scissors.
Ah, I love that analogy.
Yeah, so the infected cell might release new viruses, but they are totally immature, defective, and entirely harmless.
It's a multi-pronged attack. If the virus uses this mutation engine to evade the fake building blocks, the molecular scissors are still jammed. It just traps the virus from all sides.
It does. However, managing these combinations requires incredible precision from doctors. The clinical text details severe adverse effects that have to be monitored.
Like what?
Well, for instance, the highly effective NSTIs, they're known to cause significant weight gain and metabolic changes. And tenofovir disoproxyl fumarate, which is a common NRTI that can slowly degrade bone density and impair kidney function over time.
Oh, wow. So it's a real balancing act.
It absolutely is.
And the most incredible example of precision medicine here involves the drug abacavir, right? Because before a doctor even prescribes it, the patient must undergo genetic testing.
Yes. It is a really profound intersection of genetics and pharmacology. They test for the HLA-B5701 allele.
Because if you have that specific genetic marker, you just cannot take the drug.
No, you can't.
And this isn't just about a mild side effect either. Your own immune system will actually mistake this life-saving medication for a deadly pathogen, which triggers a severe, potentially fatal hypersensitivity reaction.
Right. It's one of the clearest examples in all of medicine where your personal genetic code dictates an infectious disease treatment.
That is wild. But when clinicians successfully navigate those genetic markers and the side effects, the results reshape global health.
They do.
Because the primary goal of RT is sustained virologic suppression, which is defined as dropping the viral load below 50 copies per milliliter of blood.
Yes. And when a patient hits that threshold, they are classified as undetectable.
Which leads us to arguably the most important public health equation of our time. U equals U, undetectable equals untransmittable.
The revolutionary.
It really is. By controlling the virus inside one individual, you actively sever the chain of transmission for the population. Treatment is prevention.
And the clinical data supporting U equals U is rock solid. If a patient maintains an undetectable viral load, the virus cannot be sexually transmitted to a partner. It completely removes the fear of transmission from relationships.
Wait, I do want to clarify the boundaries of that statement, though. Because when people hear a phrase like cannot be transmitted, it sounds like a blanket guarantee for every single situation. So does an undetectable status mean transmission is 100% impossible in all scenarios?
That is a very vital distinction to make, and the source material is very specific about this. While sexual transmission and transmission via shared injection equipment are effectively eliminated, the virus can still be transmitted perinatally, meaning during childbirth or through breast milk.
Okay, so it's not impossible everywhere.
Right. The concentrations of the virus in those specific biological compartments, they can differ from blood levels. So U equals U is revolutionary, yes, but doctors still employ strict preventative protocols during pregnancy and nursing.
And the preventative arsenal extends to people who don't even have the virus at all.
Right.
Like pre-play app, Pre-exposure prophylaxis, which is a daily pill or a long-acting injection taken by HIV-negative individuals to prevent infection. And PP, post-exposure prophylaxis, which is an emergency regimen taken within 72 hours of a potential exposure.
Furthermore, for patients who are diagnosed late, meaning those presenting with a CD4 count already below 200, the guidelines dictate an immediate two-front war.
A two-front war.
Yeah, doctors administer antiretrovirals to suppress the HIV, but they also preemptively administer prophylaxis like the antibiotic cotrimoxazole.
Right, because you can't just fight the HIV if the generals are already dead. You have to actively shield the patient from opportunistic infections like PCP or toxoplasmosis while you wait for the immune system to slowly rebuild its ranks.
Exactly. The pharmacology is undeniably brilliant. Yet the Stat Pearls text dedicates significant space to a pretty sobering reality.
Yeah.
Science alone cannot stop a virus if human behavior, stigma, and legislation build a wall between the patient and the clinic.
The psychological toll in HIV diagnosis remains massive today. Patients often battle intense self-stigma. They internalize societal fears, which leads to isolation and tragically prevents them from picking up the medication that would render them untransmittable.
And the legal landscape heavily influences this dynamic, too. The clinical text uses Florida as a prime case study here.
Oh, right.
Yeah, the state mandates strict epidemiological tracking. So if a clinic diagnoses a new case, they are legally required to report that positive result to the state health department within 2 weeks.
But the flip side of that law is an absolute fortress of patient confidentiality.
Yes, it is.
If a healthcare worker breaks that confidentiality, Florida law classifies it as a first-degree misdemeanor. That carries up to a $1,000 fine and up to a year in prison.
The severity of that punishment is entirely designed to ensure vulnerable people feel safe enough to get tested without the terror of public exposure.
It makes sense.
It does, but broader structural barriers persist globally. The sources point out that laws criminalizing HIV exposure or criminalizing marginalized groups like sex workers and people who inject drugs, they actively undermine public health initiatives.
Right, because by criminalizing those behaviors, vulnerable populations are driven underground. They're pushed far away from testing centers and pre-EP access.
Precisely. And the numbers in the text make a very direct mathematical point about this. A 2015 epidemiological study cited in Stat Pearls estimated that decriminalizing sex work globally could avert 33% to 46% of all new HIV cases over a decade.
And just to be entirely clear to you, our listener, we are strictly reporting the epidemiological findings exactly as they appear in the clinical text. We are not endorsing a political stance or advocating for specific legislation here.
Not at all. We are simply conveying the data presented in the source material regarding what mathematically impacts transmission rates on a population level.
So what does this all mean? It means the battle against this lentivirus isn't just fought under a microscope with molecular scissors and fake genetic building blocks.
No, it's not.
It is fought out in society against stigma and systemic barriers. The most sophisticated anti-STI drug on Earth is completely useless if the person who needs it is too afraid of the law or society to walk through the clinic doors.
That is so true. But if we connect this to the bigger picture, the trajectory is still one of immense hope.
It really is.
The United Nations has mapped out the 95-95-95 goals. That means achieving 95% of all people living with HIV diagnosed, 95% of those diagnosed on antiretroviral therapy, and 95% of those on therapy achieving viral suppression.
It is an incredible testament to human ingenuity. We took a virus that defined the panic of the 1980s and 90s, we decoded its blueprint, and we built an arsenal that allows people to live long, vibrant lives while stopping transmission dead in its tracks.
There is, however, one final clinical detail from the text that we want to leave you to mull over.
Oh, yes. The sanctuary sites.
Exactly. Because HIV integrates directly into human DNA, it establishes what researchers call sanctuary sites.
And what are those exactly?
These are anatomical spaces like the central nervous system and the deep tissues of the lymph nodes. Antiretroviral drugs actually struggle to penetrate these areas effectively.
Okay, so the drugs can't reach them.
Right. So while the blood is completely clear of the virus and the patient is thriving, a tiny reservoir of the virus simply sleeps in those deep tissues, quietly embedded in the genome.
Wow. So the fortress is secure, the guards are on duty, but the invader is just asleep in the basement, waiting.
Precisely. And that represents the final frontier of this pandemic. The scientific future isn't just about creating stronger drugs to suppress the virus in the bloodstream.
Right.
It is the mind-bending biological challenge of figuring out how to pick the lock to those sanctuary sites, safely wake the sleeping virus up, and flush it out of the DNA for good.
What a thought to end on. Thank you for joining us on this deep dive. Keep asking questions, keep challenging what you think you know, and as always, keep learning.